We are live now, doctor.
Good evening, everybody, and welcome to Yosi Retina Surgical Wars Episode 2. Today, we have an interesting session lined up for you. We have the Retina Warriors, Dr. Amit Nene from Isha Netral in Thane, Mumbai, Dr. Ashish Markan from AIMS, New Delhi, Dr. Mayank Bansal from Caritas Eye and Retina Institute, New Delhi. We have the War Council from Dr. Danish Ratra, Shankar Nethralaya, Chennai, Dr. Divakant Mishra, Swaran Jyoti Group of Eye Hospital, Lucknow, and Dr. Kaushik Tripathi, ASG Eye Hospital, Kolkata. We have the battle commanders, me and Dr. Nikita Gupta from Center for Sight, Delhi, and we have the intravitreal armamentarium, which is Dr. Karthik Singh from ASG Eye Hospital, Varanasi, and Dr. Harpreet Kaur from Eye Care Eye Hospital, Noida. So I'd like to invite everybody on stage and let the battle begin.
So we'll be starting with the videos first and followed by the two talks. And from the video, we'll start first with Dr. Mayank Bansal from Claritas Eye and Retina, Delhi. His topic is the delicate fix via surgery for submacular bleed. Dr. Mayank Bansal, over to you.
Just a minute. For Dhanasri ma'am. Ma'am, we are doing a marking for this entire presentation where you have 20 marks and Dr. Divakant and Dr. Kaushik have 10 marks each. We'll be announcing the winner at the end of the presentation.
And Dr. Karthik, some marks for the audience as well.
Yeah, every poll has 1 mark from the audience side.
So we'll do that poll in the end. I think, can we request, Dipanshu, can you discuss with the numerotech regarding the polling, which we'll bring up in the end?
Got it.
Great.
Please go ahead, Dr. Mayank.
Over to you, Dr. Mayank.
Great, excellent. So, well, it's a pleasure to be here and just sharing 3 cases of subretinal hemorrhage. The first one is a patient who had a cataract, along with that a vitreous hemorrhage that was there. After taking care of the cataract, we saw a whole bleed, and once we cleared off the bleed, the hemorrhage, which was subretinal, was both new as well as old, and pretty extensive, definitely. So yeah, I'll first just see through how. So yeah, that was our view after clearing of the vitreous hemorrhage. The posterior vitreous detachment was already there, and yeah, the hemorrhage being extensive, we chose a site which was not right in the center, but at the junction of the elevated parts because of the subretinal bleed, and both closer to the inferior arcade as well as the superior arcade made 2 bleps, and then thereafter did a air fluid exchange. The drugs that we used was tissue plasminogen activator, as well as at a overall dose of 50 micrograms, along with Aflibercept, actually in this case. And overall volume of all of this was kept at 0.2 ml. And then after that, did an air fluid exchange and subsequently injected gas inside the eye. So that was 20% SF6. So one of the key things while injecting was to not do a very sudden injection so as to avoid a macular blowout. And although the bleeding resolved, the patient had a chronic bleed. So the vision improved mainly from hand motions to about 2/60. But that said, the patient was overall happy with the even a mild increase in the vision that was there. This also underlies that how important it is to perhaps go ahead with immediate treatment of these patients who have a subretinal bleed in the first place. So coming on to the next case, here we had a patient who again had a CMEM scar, along with that a massive subretinal hemorrhage. So just giving intravitreal injection of tissue plasminogen activator or a gas ball would not have been a great option. So we went ahead and injected subretinal TPA, And again, a very similar approach wherein we're going not in the center, but just at the elevation where the bleed and the retina is there, so as to minimize trauma, as well as go very slowly so as to not cause a macular blowout. And since there was a scar in the middle, so chose two sites, both superior as well as inferior, to cause the blebs. The gauge of the instrumentation for the vitrectomy was 25 for all the cases, and the gauge of the subretinal cannula has a 38 gauge on the outside and a 41 on the inside. Following the subretinal injection, again, had the patient maintain did a air fluid exchange, and along with that, a 20% SF6 gas. This patient, incidentally, post the procedure, had a breakthrough bleed, which you could say. So as the gas absorbed, then there was some amount of vitreous hemorrhage, which required eventually a vitreous lavage, but the bleed had cleared off. So the patient's vision improved to 636, if I recollect correctly. Yeah, this is the final image for the patient. And the last patient was someone who had a 3/60 vision and a cataract, of course, and along with that, the need to address the subretinal bleed. So here, personally, I had a debate whether to go ahead with this subretinal because the bleed was perhaps not as extensive. But then that said, given all of the discussions with the patient, we went ahead with it. And yeah, again, the same thing, to not cause a macular blowout, went ahead with a slow injection and a fluid air exchange and gas at the end. Here, the patient improved to 6/36. So yeah, a summary of all these three cases. I'm happy to take any questions now.
Thank you, Dr. Mann. That was an violation of cases. I'll open the discussion to the panel. Dr. Dhanashree, ma'am.
Yeah. A very nice presentation, Dr. Mayank. See, what I would like to first, know from all these cases is what exactly was the age of these patients, what was the, etiology, and how much was the duration of the subretinal hemorrhage? Because I think the most important aspect is the duration of the hemorrhage. Okay,
Absolutely.
so that would be, that would be the main thing I would probably take into account before deciding on this kind of a process. So,
Absolutely, ma'am. So the first case, of course, had a long standing. We actually had a vitreous hemorrhage. And while we had to operate for the vitreous hemorrhage, which had been long standing, old vitreous hemorrhage, uh, since we saw on table, so we had the preparedness for going ahead with the TPA subretinal. Uh, the other two patients, etiology-wise, PCP. So the other eye had subtle polypoid pupil changes as well. And the age of the patients was between 60 to 65, 70 years of age. The other two patients had a relatively recent bleed, which was to the order of 2 or 3 days period. So that's why we went ahead with it. The long-term the long-term toxicity because of the bleed to the photoreceptors is well known. So had it been a longer bleed, we would have probably not chosen for it.
okay. And also, I just want to know why did you choose a subretinal delivery and not an intravitreal TPA? Any?
Yeah, that was a debate, especially for the last case, because the bleed was perhaps not that extensive. But given that the other two bleeds were pretty extensive, intravitreal TPA might not have been as effective. Uh, for a smaller bleed, relatively would perhaps have gone for an intravitreal TPA along with a gas bubble for the tamponade.
So, sure. Go ahead. I think maybe I can come back to you again later if needed, but maybe Kaushik can go ahead with the next questions.
Dr. Mike, it is said that we should not combine plasminogen like this TPA with uh, Aflibercept. It might cleave or something. So, have you noted any clinical like change in the activity of Aflibercept if Aflibercept and TPA are given together?
Yeah. So, clinically speaking, the patients all had a excellent resolution of the bleed, as well as the CNVM. We didn't see for it to come back for the next 2 to 3 months or so. So, I think effectiveness wise, it worked well to have the anti-VEGF given in the subretinal space along. And that was the goal, that the patient need not go ahead with the procedure repeatedly. There's a more direct action of the anti-VEGF along with this.
No, my question was like, did the TPA reduce the activity of Aflibercept? Like it is theoretically.
Clinically speaking, since we didn't see a CNVM come in for the next 2 to 3 months, uh, I wouldn't clinically say that there was a reduced activity of the aflibercept. Patients did not require on monitoring on a monthly OCT basis. They did not have a fluid come back. So for about a month at least. So that's why I feel that the aflibercept did have an action for 2 to 3 months in
And
the
also, in the last case, could TPA anti-VEGA plus intravitreal gas been an option for the patient, last patient?
Yeah, absolutely. That was a honest thought that we could have perhaps gone ahead with that. That said, that was a discussion with the patient as well, the surgical risks along with the outcomes. So eventually, the patient decided also to go ahead with the surgical intervention, and yeah, and touch wood, he did recover very well. So yeah.
Great, Dr.
Devakant.
Yeah, I think great presentations, wonderfully managed, and a lot of things have already been covered in with the discussions. Just two very simple, thoughts. One is the first case, it was almost, very dense vitreous hemorrhage. So you were mentally prepared, and that, there would be a submacular bleed, and you have to, be prepared with a TPA and all, or some
There was a
investigation
history,
did
yeah. Yeah, so absolutely. So the ultrasound, of course, showed a PVD which was already there. And there was some previous history of receiving injections. Compliance had not been the case. And on that note, actually, that most of these patients who've had a subretinal bleed, when you go into the etiology of it, that one, of course, PCVs, they tend to bleed. Second, that the patient has perhaps not been on so much of a follow-up. They haven't been receiving the anti-VEGF. So it's gone to that stage of actually going into a full bleed. Third, that perhaps the patients are on anticoagulants or maybe even hypertensive. So that also increases perhaps the chances of bleeds. And there are reports on that as well. So coming back, yeah, to your question, that, yeah, absolutely, the patient had a previous history but had not been compliant. So we somewhat had presumed there was no other there were changes of wet AMD in the other eye. There wasn't a very strong history of hypertension, diabetes, or anything. So the likelihood seemed to be towards this. The ultrasound, of course, didn't help us pick up a submacular bleed as much. But yeah, that's why we were somewhat prepared for it.
Yeah, so that's an interesting takeaway. With these, clinical points, we can, should keep TPA in our armamentarium whenever managing such cases. And one, because a lot of young surgeons, see these programs. So any tips of, again, with the first case, it was almost with such dense hemorrhages. These are blind vitrectomies. So just some tips for our young surgeons, how to avoid, cutting the retina and, complicating the things further.
Yeah, perhaps one of the keys that I try to follow is to perhaps keep the vitrectomy cutter a little more anterior. We'd already done the cataract surgery, so of course you want to avoid touching the lens, but then keep the vitrectomy cutter facing upwards, and perhaps not go very posteriorly, cut it layer by layer until you're able to see some part of the retina. That's something we obviously pre-operatively had evaluated that there's no retinal detachment, so we knew that that was a safe space to. I also wanted to add on the surgical points on the injection. So that's something that can be done manually, which can be a little challenging. But along with that, there's sometimes that you can use the BFC or the oil injection uh, module to perhaps inject, and various ways of doing it. Now, most lately, Med1 has been making these injection modules, which you can actually connect to the silicon oil injection BFC module, and then you're able to inject it via the foot pedal itself. So that's one thing. The cost of the cannula is not very high. It's around 4,000 rupees or so. So it's also very doable to have it in your OT or so. The cost of TPA has also been coming down. So various drugs, previously Boehringer was making it, now even the Reliance Group is making it, which is way cheaper. So these are a few things which perhaps I wanted to add as well.
If I may ask Dr. Mang, do you reduce the infusion pressure when you when you're injecting subretinally?
Not particularly, because through vitrectomy in general, I like to keep a pressure of 15 or 16. So don't feel the need to do that particularly.
And usually you give 50 microgram or you start with a lower level. Sometimes you give it 25.
Depending on the degree of bleed. So the upper limit is said to be about 50 to max of 75 or even 100. But for the last case, for example, we went in it with just 12.5 of micrograms. So, but for the first one, 50 micrograms overall.
And is there any contraindication where you don't use TPA? Like in general for TPA, we say a recent history of stroke. Do you ever ask these history or for
No, so
intraocular
that
use you don't?
TPA would be perhaps useful only for a stroke or so. But yeah, to my knowledge, there's no contraindication.
Okay. Is there any other questions from the panel or can we move on to the next?
So in my experience, actually, the intravitreal TPA also works as good as the subretinal TPA. So my suggestion to the young surgeons would be that in case they are not very confident about injecting subretinal TPA, they can simply inject intravitreal TPA and put gas. Especially when you are doing surgery for such massive subretinal hemorrhages. So it's quite dangerous. Sometimes a breakthrough can occur. Sometimes you can have on table also retinal breaks can occur, and these once they develop retinal breaks, they can they can go into PVR and all very rapidly. So you have to be a little bit careful. So even intravitreal TPA also will work.
Thank you, ma'am, for the valuable comments. I think we can move on to the next surgeon, Dr. Nene from Isha Netralaya Thane. He'll be presenting on breaking barrier, a tale of tangled retina. Dr. Amit, over to you.
Thank you so much. So, good evening, everyone. At the foremost, I would like to thank Yosi for giving me this opportunity and Dr. Karthikeyan for reaching me out. So, I will start with my video presentation now. Oh, is the video visible?
Not yet. Oh, yes.
So, this was a case of 34-year-old male with a region of hand movement. He had a total RD was off. A patient was advised surgery, but he went elsewhere. And after 2 months, he came back with this picture. I took up the case under very guarded prognosis with NPL vision explained to the patient. So the patient also had underwent cataract surgery during the same time. It was a loose suture which I had removed. Silicone oil removal was done. Now, as you can see, the entire retina has been folded upon itself. The choroid is all visible. So with the help of Alcon 23 cos ILM force, to remove all those membranes which are holding the retina together. So there were some subretinal bands also. So I'm closing that forceps and I'm using it as a dissector, like just a blunt dissection I'm doing. So at this point of time, I was thinking whether to continue with the surgery or not, because I wasn't sure whether that retina would completely open up. It had shrunk to half its size. So after removing the few membranes, the macula finally became visible. So in the primary surgery, the surgeon had placed a buckle also and had done a 360 laser, but I don't know how that entire retina came back and folded upon itself. So after removing all those membranes, The bleeders were cauterized, and finally then I put PFCL once I was sure that the retina was not taut enough. Now, as you can see at the periphery, there are all rolled up edges. So I trimmed those edges and I freshened them. Similar thing I did with the other side also. So once the retina was flat enough, then under PFCL I did 360 laser. I did at least 7 or 8 rows of laser over here. So this was the superior retina, which was, I had kept it attached just to be sure that the macula falls in place. And now once everything was trimmed off, I decided to remove that part also. I prefer to do a fluider exchange and then remove the PFCL and then put oil rather than doing a PFCL oiling. So this is the photograph taken at 2 weeks. This is at 1 month. Then the patient developed a thick ERM. So I planned his SOR within 2 months. So again, oil removal was done. So you can see the thick ERM which has been formed over there at the posterior pole. I did a PI because there were very tight additions, irido-lenticular additions which were formed. So again with the ILM process, I removed those ERM. I stained it to see whether there was any ILM there or not, but as you can see, it didn't. The stain didn't take up because the ILM had come out with the ERM. I did a fluider exchange and left it under air. This was the post-op picture after 2 months, and the patient had regained a SIF 1 meter vision. Thank you.
Thank you, Dr. Amit Nene. That was a really challenging case and well managed. Dr. Dhanashree, ma'am.
Yeah. Yeah, thank you, Dr. Amit. Really challenging, I would say, and really bold to do this case. But two, three questions I have. One is that what was the rationale for doing this cataract with intraocular lens for such a patient where the retina is so much badly, detached and PVR is there as it is. The visual potential is not much. So, what was the rationale behind doing that?
So the patient was seen by me when he had developed a retinal detachment, but he had gone to some other place later on, and over there he underwent a retina surgery first. The patient had developed cataract, and over there only he had then underwent a phacoemulsification surgery. And after 2 months, actually he was a colleague of mine who had operated, and he referred the patient back to me just in case whether anything could be done.
No, the reason I ask is that in my experience, what I have seen is that in patients who have such complicated retinal, problems, who require a lot of retinal manipulations, like say diabetic patients who have got a very bad TRD or very bad PVR, they eventually develop a lot of post-operative inflammation. And if you are also combining it with cataract surgery with intraocular lens, that further, adds to the inflammation. So these patients will end up with a very bad anterior segment. You will have a lot of membranes, lot of adhesions between the iris and the capsule. The lens may get distorted, displaced, and all. Then you will have a very thick PCO also. and they also tend to develop a lot of membranes posteriorly. So like you had an ERM, you can have membranes along the RR edge, and then RR edge will get lifted up. So I generally prefer to either not do the cataract surgery at all, do only the retina surgery, or then just do a lensectomy with rest of the retina procedures, just to limit the amount of post-op inflammation that they can throw up. But a very challenging case really. Second thing is, maybe of course it could not have been avoided, but the retinal RRH was going very close to the optic disc.
Yes.
So yeah, so one of the, for the young surgeons here, one of the downfall is that if you do laser so close to the optic nerve, there is a possibility of getting optic atrophy. So in fact, in your case also, we can see that there is a optic nerve has become slightly pale. Of course, sometimes you cannot help it if the tear was very close to the disc, then that would happen. And the third thing is that you kept one small area of the retina which was attached peripherally, superiorly, and then you said that after the macula was placed, then you detached it. So sometimes we can do that, especially I do that if I'm not using PFCL. So some of the patients who cannot afford PFCL, in those patients, I leave some small tags of the retina attached to the posterior, to the peripheral. But these tags are like very small tags, so which can be easily broken later on. So once the retina is settled with the fluid air exchange, then I cut all those tags. But if you are using LPFC, then probably no need to keep a tag like that, because with LPFC anyway the retina is going to get settled. Thank you.
Thank you.
Dr. Kaushik, sir, or Dr.
Dr. Abhi, very nice surgery. This is a very demanding surgery, and many people will not touch also such cases. So very nice. So, what was the rationale for this was pseudophakic lichen. What was the rationale for PI? Like, how will that help?
So there were too many synechiae which were formed. So that is why I decided to do a PI. Nothing else.
Okay. And like basically, during retinectomy, what we have seen, if we are not cauterizing, is it behind. So the subretinal bleed or bleed may be very severe. So there were, when you are doing retinectomy or pressing this, so basically I think it would have been better if like we the area faces large retinal facing. So it did not have any bleed, but bleed can happen in such large retinectomies and it can become very messy. Hello?
Yes, Dr. Kaushik, you're audible, but in between your voice broke.
Can you repeat just the last part? We could
Yes,
not hear
it's
about
actually
it.
I was saying like before retinectomy, it might be a good idea to diathermize the areas at least the large vessels which are there, because it might cause bleed and which can go subretinal and it can be difficult.
So actually, in this case, there was no need of any retinectomy. The entire retina was fallen back.
No, the pressing of the retina, also the peripheral crumpled part which you cut. So it like some diathermy could have helped.
Okay.
Yes, I also agree
before
with that, what Kaushik has said, because when you develop bleeding at the RR edge, you are not able to do laser very well at the RR edge. And this will later on cause problem, because then your retinotomy edge will contract and lift up and you will get recurrence. So at all cost, I think you must avoid bleeding at the RR edge.
before we go to Dr. Devakant, can we take up this question from Dr. Tanya Jain? Is there any specific reason why you avoided a direct PFC or oil exchange and went for a PFC layer and followed by an air oil? Dr. Amit Nene.
I'm more comfortable with this. No reasons for it.
Right. Dr.
So
Devakant, sir?
actually, can I also give a comment?
Yeah, sure.
I think probably, of course, it depends on what you are comfortable with. So we routinely do a PFCL oil exchange. The only problem with doing PFCL air and air silicone oil is that sometimes when you are exchanging with air, the GRT or the RRH may slip, so it may slip back. So you may have, or it can fold. If you have a GRT, it can fold. So that is the problem. When you have PFCL oil exchange, that kind of a thing happening is a little bit less. So I would say if you have a large GRT or if you have a 360-degree retinotomy, then it would be better to do a PFCL oil exchange rather than do PFCL air exchange.
Dr. Devakant sir.
Yes, Dr. Amit, great case, and a lot of us would not attempt it, right? It's a wonderful case. Congratulations. Just, I mean, in 360 degree RRs, I still in these cases I limit my lasers. I feel it leads to more ERMs and membranes formation. So I would limit the lasers. But again, wonderfully managed case. And yeah, that is it. I think all the points have been discussed. So.
Okay, thank you, Dr. Amit, once again.
Thank you.
And we move on to the last presentation by Dr. Ashish Markan. He'll be presenting ocular oddities, the art of extracting the unexpected. Dr. Ashish.
Yeah, thank you so much. So at the outset, I'd like to thank Yosi and especially Dr. Karthike for reaching out to me for this video presentation competition. So the title of my presentation is Ocular Oddities, the Art of Extracting the Unusual. So I'll be basically discussing various scenarios where I try to remove some of the very unique intraocular foreign bodies, I would say. So I'll just start the presentation. So the first case was basically a case which was referred as a dropped nucleus. It was a hard nucleus. And we started with a phacofragmentome. While doing phacofragmentation, suddenly there was a loss of vacuum and the phacofragmentome tip, it broke off. So it was like a fracture of the shaft of the phacofragmentome. So this has happened for the very first time with me, and probably it happens when the instrument gets a little older. EFCL was put, then using an serrated foreign body forceps, the shaft of the broken tip was removed, the sclerotomy site was sutured, and finally the surgery was completed. This is the second case. Patient presented to us with intraocular foreign body. He was working on a sewing machine and suddenly something snapped inside his eye, but there was no perforation which was seen externally. There was an extra occult perforation, but inside we could see that there was this large intraocular foreign body which was actually a sewing needle. So I decided that I'll do a clear lens extraction first rather than removing it from the sclera. And then using an external magnet and an internal magnet both, this large sewing needle was removed from the eye. And finally, a 3-piece intraocular lens was placed in the sulcus. Third case is when a cornea colleague of mine called me for basically she was doing a dissect surgery and it was a dissect tissue which had fallen down posteriorly. It was a case of scleral fixated IOL. It was a slightly decentered IOL, and somehow while injecting air in the AC, the graft went inside the posterior chamber. So I did PVD induction. Following this, you can see the dissect graft being tumbling inside the vitreous cavity. Then using the ILM forceps, I just lifted it up and brought it towards the edge of the scleral fixated IOL without moving the IOL, and very gently just brought it inside the anterior chamber. So once this was done, then finally using the main port 3.2 incision, which was initially made, the graft tissue was removed and the patient was again planned for a dissect surgery later on. Fourth case is when I was doing a normal routine surgery, retinal detachment case using a DDMS, and suddenly the tip of the DDMS, it just broke off from the DDMS and it just fell on the retina. I just initially thought maybe it will come with the cutter, but actually it was a diamond and it did not come into the cutter. I tried a couple of times, then finally used a ILM forceps, held it with the ILM forceps along its longitudinal axis and gently removed it from the eye without causing any damage to the lens. Fifth is a case of an epiretinal membrane had a pseudo hole. While I was injecting the dye, suddenly the entire green tip from the cannula just fell off onto the retinal surface. And this was again a big surprise, but nothing to worry. Just using the ILM forceps, the tip was very gently removed from the cannula itself. And then the surgery was completed, but still this was not the end of the disaster which could have happened. Once the ERM was peeled, now again I decided to inject the dye, but this time I actually used a blunt tip cannula. And oh, there was a blast injury to the retina. There was this minor retinal break which formed, and there was this minor bleed which happened. But immediately did a fluid air exchange and lasered that focal area. Finally, at 2 weeks, everything was fine. There was no detachment which happened. This is the last case. This was again a case of a scleral fixated IOL, which I had done a couple of days back, but it slipped back. Then using a 27 gauge MIVS assisted technique, which I recently described, I decided to get hold of it and take it out. But to my surprise, there was no prong of the max grip forceps. One end was already missing. I initially thought maybe the assistant gave me a wrong forceps, and I just for somehow completed the surgery. But then I did an indirect, and I saw that max grip was actually lying on the tip of the max grip was lying on the retinal surface. So I picked it up and tried to bring it using a bimanual technique, shake hand technique. I tried to bring it out, but somehow while I was taking it out through the sclerotomy site, it got stuck at the ora serrata. And it sometimes happened with all of us that if the wound is not very large, then used a magnet, picked it up with a magnet from the ora serrata, slightly enlarged the wound, did a conjunctival excision there, and then easily removed it. Thank you.
Thank you, Dr. Ashish, again for amazing compilation of cases. You seem to be having a lot of amazing instruments falling and you picking them up. Let's go to Dr. Dhanashree ma'am for her comments.
Yeah, congratulations, Ashish. Very wonderful cases we have shown, and yeah, very nicely managed also. This is quite common because we keep reusing our instruments, and oftentimes, with reuse they become weak and they can break and fall inside. So we have also had many occasions on which we had to retrieve blades of the scissors and all that. But you showed some really, surprising the fragmentome tip and the sewing needle, which is really, difficult to understand how it can go inside. So, what is your, guideline up to what size of the foreign body that you would like to take out through the sclerotomy, and up to what size then you would sacrifice the lens and bring it out through the.
Yeah, so we have already published this also, and it is like if it is less than 5 millimeters, we try to remove it from the sclera. But if it is more than 5 millimeters, I'll always prefer a limbal wound. In this case, though the diameter was not more than 5 millimeter, but because it was too big a foreign body, it would have caused a lot of damage at the vitreous base. That is why I decided, because patient also had some sclerotic changes in the lens, some cataractous changes in the lens, and patient was already told that he might be taken up for lensectomy. He was already prepared. So that is why rather than doing a repeat surgery later on, I planned it doing in the same sitting.
And then you put the lens sulcus.
Yeah, a
That,
three-piece lens was
that's
placed
great.
in the sulcus.
Yeah. And also, second thing I want you to answer is, do you do PVD induction and remove the posterior vitreous before you remove the foreign body, or do you leave the vitreous, as a
Yeah,
cushion?
I preferably do a PVD induction, and if I require to save the macula, I'll put a PFCL bubble on the macula rather than leaving a skirt of vitreous there.
Okay, I agree with you. I also prefer to do PVD induction and vitrectomy first.
Yeah,
All right, thank you.
thank you.
Dr. Kaushik, sir.
Very nice surgeries, very challenging surgeries,
Thank you.
but all cases are managed very well. Very nice. My question was like because the corneal surgeon was not planning to put the same dissect flap, so could it have been removed like with
I
cutter only?
uh, uh, with the cutter. No, actually, even this was the first time I had encountered a DSEC tissue. When they called me in the OT, I initially thought that DSEC must be a very fragile tissue, and I could even cut it with the cutter itself. I was imagining that it must be something which is folded upon itself, maybe like a DMEC tissue. But it was quite thicker tissue, and I don't think it is easy to remove with a cutter because it has corneal stroma also in it. And I initially told them that, do you want me to put air in the AC and stuck it back? But then they told that probably there is loss of a lot of endothelial cell loss, which must have happened. So they planned for a elective re-dissect surgery later on.
And no, actually, I also do not have any idea. I want to ask the panel and the nursery ma'am if similar thing has happened. Basically, this is very extremely rare thing which you have encountered. And another thing, if you are like if there is a break in the posterior pole inside the arcade during a PFCL injection or other injections, if it is a small break or even a large break, it usually doesn't lead to RD. Retinal detachment doesn't happen even if you do not laser. So this is one thing which my mentor told, and I have also seen. But if you can laser it post-op also, or you can put a single row of laser. Because
Yes, sir.
posterior pole breaks will not most likely lead to RD.
Totally agree, sir. Like in some of the cases of neurocystic cirrhosis, also if we remove them from the macular area with a small retinotomy, sometimes we leave them unlasered and nothing happens. Yeah, totally.
But since the cases were really great and very, very rare, maybe you were unlucky, but you managed very nicely. Very nicely.
Thank you, sir.
Dr. Devakant, sir.
Yes, Ashish, again, congratulations on, being there at the right time and very nicely managed. And our team member, Dipanshu, has decided that if you win, we'll gift you a set of new instruments. So you
I
don't
think
have
you will have to send it to the AIMS, or I'll have to keep my personal kit of instruments.
they'll not accept our gift, I'm sure. But coming back to that question, Dr. Kaushik had asked, we had a similar, DSEC thing. It's very difficult to, cut it out with a cutter. So I
Yeah.
think the approach that he took was great, and it's not possible to utilize it with so much of turbulence and everything. The cornea surgeons are not happy with the endothelium that will be there. But again, great cases, wonderfully managed, and I hope that we don't see these cases in our practice. Most of them. Yeah. Thank you.
Thank you.
If there are no more questions, then we can move on to the talks.
Yes. After a session of great surgeries, now we move on to the intravitreal armamentarium. And first, I'd like to invite Dr. Karthik Singh, who will be talking about beyond treat and extend multidisciplinary approach to exudative PCV.
And before Karthikeya starts, I think we wanted to do a poll and have audience opinion also. Somehow the poll is not working, so maybe we can use the chat box, and if everybody can just give their top presenter. Is that fine, Karthikeya, Dipanshu? I think that should work. All of us can poll in the chat.
Yeah,
We'll have some data.
we can do that.
And in the meantime,
Do we
we'll...
just mention, we should mention only the top presenter, is it?
Yes, please. Yeah, just Dipanshu, can you officially announce so that we can...
Only in the chat box you have to type out the name, all the participants who are there, so that we can take a poll finally at the end of it.
Karthikeya, I think you can proceed with your presentation.
My screen seen?
Yes.
Yes.
Perfect.
Okay. So I'll be talking about PCV, few cases, only three cases here. I'll be talking about how we go about PCV in the day-to-day practice as we see most of the places, because most of the time we don't have the armamentarium of ICG and all those things, or even PDT for say. So how we go about only with anti-VEGFs or Aflibercept, which I'll be talking about the same. So this was one update on polypoidal choroidal vasculopathy, where they said in many, a minute. In many cases, it may be appropriate to start the initial treatment with anti-VEGF injection alone. In the patient who do not respond to anti-VEGF, the potential in the patient who do not who respond to anti-VEGF, the potential but the rare complication of PDT can be avoided. So this was one of the initial perspective on PCV management, what we follow usually in our practice. In this article in Indian Journal of Ophthalmology, which was published by SN team, they said they did the initial experience of only anti-VEGF in the 7 patients, and they found only 1 had a deterioration of vision, while other 6 had significant improvement in their vision. In this article, by scientific reports, intravitreal Aflibercept for active polypoidal choroidal vasculopathy without polyp, they also found that intravitreal Aflibercept significantly improved the visual and anatomical outcome of PCV that manifested with exudation from the BVN after pre-treatment with PDT or any other anti-VEGF other than Aflibercept. This is one of my very important clinical sign which I do follow in my PCV cases. That is pre-choroidal cleft in the eyes with neovascular AMD. And if we see this sign in the eyes with PCV, I have noticed that we tend to inject these eyes more, and also we have to monitor them very frequently. Even if the disease is quiet, I do call them 2 monthly. I somehow see very frequent recurrence in my practice if I see a pre-choroidal cleft in these patients. So I'll directly go to my first case. So this was a case of 64-year-old male who came with DOE in both the eyes. BCVA in the both eyes was 6/9 partial. And this was long back, and then I had some primitive OCT, and this was a picture in right and left eye. You can see this notch PD and very limited SRF or IRF in this picture. I also did FFA for this patient, but I was not finding any kind of leak, but he was having symptomatic DOV, and some exudation was seen. And I decided to go with the injection. With injection, he was symptomatically better, and his vision also improved. But then I decided to go with the second injection 2 months later. And now this was a picture before the injection. And this was a picture after the second injection. You can see that the exudation actually reduced. And now some IRF which was there at this point, that has also come down. Now on the third follow-up of November, now this was also almost after 5 months. Now I can see that the right eye was very well, and the left eye still there is some kind of PED is there. Now the notching was gone, but still PED was there. Now I decided to go with the third injection in this eye, and now I can see that now it started flattening in this eye as well. But now this is not the end of the disease. So PCV sometimes it takes a lot of your patience, and that's what I wanted to show for this. Now I have a series of OCT for the same patients. Now you can see that right eye is remaining quiet, not doing any kind of trouble. Now left eye was also okay. This was almost after 7-8 months. OCT angio is not showing any significant change. Right eye again is okay, but now you can see this pre-choroidal cleft has come, and now patient is symptomatic again in the left eye only. In the OCT angio, I'm not finding anything significant, only some increased vascularity. Now I decided to re-inject. This was the fourth injection in this eye. Now you can see that height of pre-choroidal cleft has come down. Some IRF which was developing, it has come down, and also the SRF which was developing has reduced. Nothing significant on the OCT angio. Now again, you can see some SRF has developed with some kind of haze around in the manual segmentation, but again, no significant network was noted. Now this was a sixth injection for this eye. Note that pre-choroidal cleft which is there. With every injection, the patient got symptomatically well. Now you can see some thickening which is developing in the hyaloid face as well. With the repeated injection, we do see this sometime, and which we sometimes call it central posterior hyaloid fibrosis syndrome as in this patient. But luckily with the seventh injection, this was gone, and he did not develop any kind of VMT or such sequelae in this eye. So just to emphasize on how this pre-choroidal cleft as a single standalone it can be standalone determinant for a very long-term disease in these cases. And while the other eye, right eye, was not having this, and I could see that it was very stable for a very long time. So now the next case I wanted to show was a one eye patient where he presented with a large submacular bleed. The vision was dropped to CF 1 meter, and I decided to do. I actually first did Aflibercept along with pneumatic, but nothing was helping. So one-eyed patient, and this was the other eye where you can see that the discolor is there, and also entire outer retina was gone. And this I decided to go subretinal did subretinal TPA along with intravitreal Aflibercept. Now you can see some lamellar hole is developing, but luckily this patient had very good outcome post subretinal subretinal TPA, and he improved to 6/12. Now this was a follow-up again. He was maintaining the vision of 6/12 for almost 1 year. Now you just keep seeing the video. Again, the fibrosis has reduced and the vision was still the same. He was very happy. Now, on this follow-up, he started having some symptoms. I advised FFA, he did not undergo, and then he came up with this. And he came with this kind of bleed. Now I thought that I have already done vitrectomy, so I'll just do one more pneumatic trial with Aflibercept, but it did not help. So again, I decided to do subretinal TPA along with Aflibercept, and this was the second surgery for the same eye. You can see the blood is gone. It is very hazy under the gas, and now the last OCT was taken. Now he has improved to 6/60, but luckily some vision was saved in this eye. So sometimes it is beyond our scope to just treat with anti-VEGFs alone, and we have to intervene in these eyes and to save some kind of functional vision. Yeah, I think I should have given intravitreal TP as well during the second pneumatic, but I decided to do it subretinal and go full throttle. So this was a third case, and this is one case where I have monitored for a very long time, and this was a case of exudative PCV, where you can see this right eye was almost gone. Nothing could be done in this eye, and this left eye, C came with the symptoms in the left eye. Some IRF, some SRF was there in this eye. Now I decided to go for the first injection in this eye, and this was a picture in this eye, and this was mixed kind of PCV. But after second injection, now you keep noticing this this hyaloid which is there. Now this will keep thickening over the course of the injections. With every follow-up, he used to come with new IRF, and now this hyaloid is getting thickened. Now I have given the third IV. So he already received few other anti-VEGFs before reaching me out. I was thinking that now this hyaloid will detach with the repeated injections, but it was not. I kept her under TNE also for some time, but now this tractional component was coming. Again, this patient was also practically one-eyed, so I was thinking to avoid the surgery as much as possible. Now I gave the 5th dose of intravitreal Aflibercept. Again, now it kept thickening. The hyaloid kept thickening, and I was not able to think on the lines of surgery for her, because I was thinking that even with such kind of edema, it might go to de-roofing as well, and she might lose any functional vision, because she was maintaining 6/60 vision in this eye despite all this traction. Now this was the 7th injection. The hyaloid even thickened further, and now I could make it out that it will not detach with just injections. I was doing TNE again and again. Now I decided to give one more injection before taking her up, because now she was having a lot of symptoms. Now I actually took her up for the surgery. I thought that I just cut the traction and nothing else to be done after that. Very carefully, I was proceeding with just cutting the traction like we do in segmentation. So I actually segmented it, and I thought that I'll just leave it. But while inducing the other part of PVD, it actually came out as a whole, and there was no de-looping as well. So I completed the vitrectomy and it was filled with gas, short-term tamponade. This was a pre-op and this was under the gas. I could see that there was no traction. But post-gas injection, now she got excellent vision gain. Now she is having 6/12 part post this. So for this was the other eye, nothing could be done. To the council, I want to ask, when was the right time to take up further surgery? Any other line of treatment that would have helped this patient? When will you consider for re-injection despite no activity in such patients? And how ICGA would have helped differently for this particular case? Ma'am.
Yeah, a very interesting case, Kartikeya, and definitely challenging case because there is a dilemma about this case, definitely. But having now seen the entire course of the case, I think maybe it would have been better to operate earlier because what you were seeing is that there was a traction component, and with your repeated injections the traction was in fact the hyaloid was getting a little bit thicker and the traction was not getting relieved. And if you see the subretinal component actually did not change much, except maybe towards the latter part. It is mainly the subretinal part which was under the traction. That was the one which was showing some different configuration. So maybe retrospectively thinking, I would have taken up for surgery earlier, especially given the good outcome of the surgery. So I feel maybe uh,
Yeah.
yeah, now we are now, after having known the result, we are wiser. But if I feel the tractional component is more, now this is actually an AMD case, but if you have a DME case where you have some amount of ERM, some amount of this hyaloid which is adherent, and there is a slight traction on the macula. It's not exactly a TRD, but there is a slight traction. So there is always a dilemma whether you should give injection in this patient or whether you should operate. But I feel whenever there is a traction component, it is better to do surgery because with anti-VEGF, first of all, the traction might get worsened because your fibrosis will increase, traction may get worsened, and you may in fact precipitate more TRD. So, and as long as the traction continues, the macular edema also will not settle. So maybe it would be good idea to operate earlier rather than continuing further injections. And your next question is maybe Kaushik and yeah, anybody can answer. Yeah. Thank you.
So what other treatment, like obviously injection could have been like repeating the same injections could have been an option, but because the vitreomacular traction and the distortion to the fovea was actually increasing, and the thickness of the traction, it was also increasing. So I think I would have also gone for surgery only. And it is also seen that after surgery the vision improved. And
Yeah.
what was the other question, Karthik? And
Uh,
I'll suggest Karthik
ICGA,
that
how ICGA would have helped this case? Any input of ICGA?
basically ICG we do not have. Most of the private practitioners do not have. So I would like other people who have. I do not have a great experience with ICGA. So
Dhanasri
if
ma'am,
any
can you answer this?
Adams madam, please answer this.
Yeah, see, ICG will not help. ICG will only tell you whether activity is there or no. But that anyway, clinically also you are able to judge, and with OCT also you are very much able to judge whether activity is there or no.
Right.
So I don't think the ICG would have added any value to this. Maybe it's best to continue with OCT, or if you want OCTA can be done. That itself will give you much more information. So ICG is not mandatory. I don't think it would add any further information here.
Madam,
Right.
some of these cases they look healed and there is no subretinal fluid and intraretinal fluid, and then suddenly they bleed. There is a submacular hemorrhage. So this usually happens to some like one-eyed patients, etc. So can we prevent that? So I have seen those cases, like I have been following up for 1 year, 2 year. There is no clinical activity which can be
Yeah.
discerned from the OCT or fundus photo or clinical examination. But these patients come after 1 week or 2 weeks, there is a massive subretinal bleed. So can
Yeah.
we prevent it anyway, or like what should we see?
Yeah, but see the characteristic of IPCV is that there is recurrences and there are sudden recurrences. So that is very much typical of IPCV, and it is very. I am doubtful that whether you can actually predict it or prevent it, because oftentimes for sometimes patient will remain quiet for many years. For 7 8 years there will be no recurrence, and you would think that okay, now patient is good, cured, and one fine day suddenly they will bleed, and sometimes it will be a massive bleed. So it can happen, but I don't think that we can predict it. And one option is to do a serial ICG, but I don't think that is very practical, because how often will you keep repeating the ICG? So that would be a little impractical. If at all you have a very high risk case, a one night patient where you are very much worried about the rebleed, maybe you can just keep them under a very close follow up. But again, OCT or OCTA Octa can definitely substitute ICG. So you need not mandatorily have ICG.
And when will you re-inject, ma'am, such patients, uh, despite no activity? Is there any protocol which you follow in that case?
Okay, so one of the thing is that you can do a treat and extend what you are doing, but like if you have a absolutely quiet lesion with no activity at all, then you can slowly taper off the injection, because IPCV is not something where keep on injecting like AMD. So probably you can stop, or you can prolong the injections, give a good interval, maybe 6 months or something. Yeah, but again, I said that depends from case to case. So if you have a very high risk case, maybe you would still continue to inject. Otherwise, you can stop and then see.
Okay.
Thank you very much for all these interesting insights. And I'd like to now announce the winner of the Retina Warriors. And the winner of the Retina Warriors is Dr. A, the alphabet A. And the rest of the suspense will be relieved after the second talk, so that we have three more presenters staying on. So over to Dr. Harpreet Kaur for the Aflibercept talk in wet AMD and DME. And hope
Hello,
it's
everyone.
short and sweet. Thank you very much.
Hello, everyone. I'll be talking about Aflibercept in neovascular AMD and diabetic macular edema. So these are the images of a treatment-naive exudative AMD with submacular hemorrhage. The patient was very old and was not very willing for prone positioning with gas. Also, the size of submacular hemorrhage was not very large. So I decided to go for an intravitreal Eylea injection. The response was better than I had expected. At post-injection 3 weeks, the submacular hemorrhage had almost completely resolved, and vision had improved from 660 to 618. After 3 loading doses, she maintained good functional and anatomical outcomes. But after 8 weeks, at 8 weeks, however, she developed some sub-RP fluid or choroidal cleft, and there was increase in the height of fibrovascular VED. So I injected Eylea again, because this is a short indicator for increased activity. Even if SRF and IRF are not there, and she improved to 612 again. Again, she developed a similar picture at 16 weeks. The BCVA had reduced to 618, and then I had to repeatedly inject Eylea at about 4 to 5 months interval. And she's presently under follow-up, and she's maintaining good functional and visual and anatomical outcomes. Coming to the next case of retinal angiomatous proliferans. So there was a lot of intraretinal lipid deposition, and on the OCT, which had predominant intraretinal fluid. The ICJ had shown a hairpin loop, which I'm not very sure of if this is the correct finding. And intravitreal Eylea was injected. This is the pre-operative image. And she had good anatomical improvement. And improved even further. The PD was gone after 3 loading doses. And it was maintained as such for the next 4 months. She's currently under follow-up and she's maintaining good outcomes. This is the next case with mild NPDR and center involving diabetic macular edema. Initially, the patient was a recently diagnosed diabetes with HbA1c of 10.6%. CMT was 352 in the right eye and 353 in the left eye. She was injected Aflibercept and she showed very good response. And it was in fact maintained over the next 6 months and most likely due to her good systemic control. This is the last case showing right eye proliferative diabetic retinopathy. There's an NV seen over here. And in the left eye, there was severe NPDR, multiple erymas present, and a lot of hard exudates on the OCT. She was injected Eylea in both the eyes, and at 1 month, her right eye edema had almost completely resolved. There was a small NST present and few hard exudates. The left eye, the edema had reduced. However, the hard exudates had organized in this picture and over here. She was re-injected in the left eye, especially for the hard exudates, and slight amount of the CMT was borderline 296. So I had injected in the left eye again. And in the next 2 months, she showed significant reduction in the hard exudates. She was also advised fenofibrate, which could have contributed to the reduction in the hard exudates. So dissolution of hard exudates is a slow process. Even the new study of Vabysmo, of faricimab, yosemite and Rhine has shown that only at the later weeks, after 50 weeks or so, the improvement in hard exudates is better with faricimab as compared to the Eylea. So this is all from my side. Thank you.
Thank you very much for a very short and sweet and crisp presentation. And now the moment that we've been waiting for. Can I just have the screen share off, please? You can see the response from the winner and the other presenters. Dr. Harpreet?
Stop screen sharing. Okay.
Dr. Harpreet, are you there?
Yeah, I'm here, sir. I cannot do it. How to do it?
Go on
You
top.
just see one.
Just like
stop.
injecting Aflibercept. Yes, this is going. Yes.
Thank you.
And so the moment we've been waiting for, I had announced Dr. A is the first alphabet, and now I'll be announcing the second alphabet. Any guesses? He is also known on Instagram as Your Retina Doctor, not mine. But so now the answer, anybody can guess, please? Dr. Ashish Markan.
Dr. Karthike, I was going to say. Okay.
Dr. Karthike has won the Deep Discussion Award.
Thank you so much.
Big congratulations, Ashish. Great.
Congratulations, Dr. Ashish.
And
Thank you.
Congratulations.
break a leg, as we say.
Thank you.
Now Dipanshu has to send him a set of new equipments, right?
Now, just to clarify, not all of these cases were operated at AIMS. So few of them
We are
were
not
at
questioning
I7.
aims.
So few of them were at I7. So you send them to Rahil.
Right.
No, we have a journalist also on the webinar, so tomorrow morning the headlines will be.
No. So just to clarify, the phacophlegmotome case was done at PGI when I was in PGI. The green tip case was also done at PGI. The max grip forceps tip was in I7, and the dissect tissue and the other ones, they were.
So it's not with the institute; it's with the surgeon. The problem is with the surgeon.
Yeah, probably. Okay.
And
Just cut down on the gym, Ashish.
Yeah, I think so. I have to.
Great. And all the winners, Ashish, of course, you and other top presenters will be invited to YosiCon for presentation. So I hope you'll be able to join there as well.
Yeah, yeah, sir. It's in Delhi. I'll be there.
Yeah, yeah.
I think you'll have to cancel your Retina.
Acha,
Yeah.
you Retina is at the same time. I
Same
didn't
dates.
realize.
Same dates.
And you'll be given undisclosed money amount, which will be disclosed in Yosi by Donald Trump. Thank you. I think we can.
I think
Who are
we
going to do
can.
Retina?
Yeah, you Retina is from 4th to 7th in
Yeah,
Paris.
yeah. Who all are going?
Ma'am, our annual meeting YosiCon is there at the same time. So
Oh, okay.
we are
Acha.
stopping others from going as well.
Okay. Okay.
So,
We are having a Uretna session in YosiCon
Uh, since
to increase the participation.
correct. Yes.
our president has given a message that anybody who will be attending the U Retina will be barred from Yosi and your membership will be revoked immediately.
Okay. Nowadays, it's become difficult to find a free slot for conferences.
Very
Every,
challenging.
every other weekend is gone.
August first week, ma'am, I think there are 4 or 5 meetings on the same day. So
Okay.
the
Yeah.
party starts from August itself.
Yes. True.
And thank you so much, ma'am, for taking out time. And it was
Thank you,
ma'am.
Divakant.
Thank
This
you,
is the
ma'am.
first time I'm attending this Yosi conference because I am no longer in the age group. But wonderful, it's such a nice time and really nice presentations and cases. Very nice. Thank
thank
you.
you
Thank
for
you. Thank
taking
Thank
you.
you
out
for
time.
inviting.
So
Thank
all
you.
the insights, man. Thank
Thank you. Now everybody is allowed to leave. Thank you.
Okay.
Bye. Good
Right.
night.
Thank you, sir. Thank
Good
you.
night. Thank you.
Good night.
Thank you. Good night.
Good night.
Thank you, everyone.
Great case, Dr. Amit. Yours as well.
Yeah, thank you, Divakant.
Yes. And I would not
Very
operate.
good.
I also operated because of peer pressure, nothing else.
Amazing. But you got good results. So
Yeah.
thank you. Thank you.
Thank you. Yeah.
Thank
Bye. Good
you.
night, everyone.
Bye. Good night.
Kartike, Dipanshu, I think we should discuss with Manjula, madam. Can we have polling from next time if it is feasible?
Sure, doctor. We'll do
Yeah,
the next.
for the next, we'll have it for all the rest of the meetings as well.
And from the YouTube
Yeah.
also. No? YouTube.
Sure, doctor.
YouTube, it will be difficult, I think. From on Zoom, we can have.
Yes,
No,
doctor.
YouTube also we can put now. There is one small icon which comes on the side. But
Is it?
yeah, it comes.
Manjula, madam, can you look into that if it is feasible to do it on YouTube as well?
No, doctor. Actually, Zoom will be
Zoom is feasible.
visible.
Okay.
YouTube, it will be
I
difficult.
think I have attended one of your Numerotech only, one ISM SICS webinar where almost 500 participants were there. We were allowed to join only on YouTube. There was one small poll button on the end. I think this was some 2-3 years back.
Okay, doctor. I'll check Mr. Sai and get back to you, doctor.
Just check it.
If Karthike has said, I'm sure it will be. So, perfect. Great. I think we had good audience and good cases as well. Karthike and Dipanshu, let's try to get out the next flyer soon so